Today's topic is tracheostomy. Tracheostomy, when it comes to the history, the term tracheostomy was coined by Nagus in 1938. Before that, it was known as tracheotomy, and the name was coined by Hister in 1780. The first successful description of tracheostomy was credited to Antonio Musa Bresovala. The word meaning of tracheostomy: stoma is mouth and tracheotomy, stoma is cut. Both words can be interchangeably used. So, tracheostomy is a stoma made in the anterior wall of trachea or window made in the anterior wall of trachea. Tracheotomy is just an incision or cut into the trachea. So, this is a tracheostomy trachea. This is the trachea with tracheal tube. So our tracheal tube has an external diameter of 1.5 to 2 centimeter in adults, 0.3 to 0.4 centimeter in newborns, and it is comprised of 16 to 20 hyaline cartilage, which are U-shaped rings. We have different types of surgical airway. Whenever there is an airway compromise, we can either opt for intubation or we can opt for surgical airways. Surgical airways are two types, that is cricothyrotomy and tracheostomy. Cricothyrotomy can be percutaneous or needle, and tracheostomy can be percutaneous or surgical. So by definition, tracheostomy is an artificial surgically created airway fashioned by making a hole in the anterior wall of trachea and the insertion of tracheostomy tube, which may or may not be permanent. So it is nothing, it is an artificially created surgical airway for compromised airways. Indications. So always, whenever there is a chance for cricothyrotomy, we should opt for cricothyrotomy. Okay, so indications are laryngeal trauma with concern that cricothyrotomy or orotracheal intubation must result in retraction of trachea into mediastinum. Second is inability to intubate or perform needle cricothyrotomy in pediatric patients. Third is laryngeal foreign body or pathology that prohibits cricothyrotomy. And another indications are prolonged ventilation, oncological resection of head and neck, and for any patient who is stable and who requires a surgical airway that can be placed in a controlled fashion in the operating room. Contraindications: when there is an expanding hematoma in the neck and whenever there is a feasibility of cricothyrotomy. Then the types: we have emergency tracheostomy, we have elective tracheostomy, we have permanent tracheostomy, and percutaneous tracheostomy. Emergency tracheostomy is employed when airway obstruction is complete and there is an urgent need to establish airway. Elective tracheostomy is a planned, unhurried procedure, and it can be either for the therapeutic purpose or for the prophylactic purpose. Permanent tracheostomy is indicated where there is a bilateral abductor paralysis or laryngeal stenosis where patient cannot breathe or function the tracheal muscles permanently. So another types of tracheostomy: high tracheostomy, mid tracheostomy, and low tracheostomy. This classification is based on the site where the tracheostomy is performed. So first is high tracheostomy. It is done above the level of thyroid isthmus, which violates the first string of trachea, and indication is carcinoma of larynx. The second is mid tracheostomy, which is doing in the second or third rings, and the low tracheostomy will be performed below the level of isthmus, below the level of thyroid isthmus. When it comes to the procedure, Whenever possible, endotracheal intubation should be done before tracheostomy. This is specifically important in infants and children. Then the patient positioning, the position will be supine with pillow under the shoulders with neck extended. This should be the position for a tracheostomy procedure. Then we have two principles. First is the cricoid cartilage and the first tracheal ring should not be cut or injured. The second is incision into the trachea should not extend below the fourth tracheal ring. So we have to perform the tracheostomy within the first and fourth tracheal rings. So when come to the procedure, these are the superficial surface anatomy that you know. We have thyroid cartilage. Below that we have cricoid cartilage, and your tracheal tube extends from here. So initial procedure is we have to provide a LA, that is a local anesthesia, usually 2% lignocaine with 1 in 2 lakh adrenaline injected into the incision line. So, steps of operation. So, first is a plan for incision. So, if you're planning for an emergency tracheostomy, your incision will be a vertical incision. And if you are planning for an elective tracheostomy, you can either place a vertical incision or you can go for a horizontal incision. So, a vertical incision should be placed in the midline of the neck, extending from the cricoid cartilage to just above the sternal notch. This is the most favored incision and can be used in emergency and elective procedures. It gives rapid access with minimum of bleeding and tissue dissection. This is the horizontal incision. With this, you can perform during the elective procedure. This is a transverse incision which is 5 centimeter long and 2 centimeter finger breadth above the suprasternal notch. It has an advantage of cosmetically better scar. Then the layers of dissection, we have following layers during the tracheostomy procedures. Initially, we have skin followed by adipose tissue, platysma, two anterior jugular veins and anastomosing veins between them, then deep fascia, strap muscles, thyroid isthmus, and trachea. So initially we'll put a skin incision. After the skin incision, we'll retract the tissues. We have to retract the subcutaneous tissues. Then the tissues should be dissected in the midline. The dilated veins are either displaced or ligated. Then we will separate the strap muscles in the midline and we will retract it laterally. Then we can visualize the thyroid isthmus. Then thyroid isthmus is displaced upwards or divided by the clamps and suture ligated. Then trachea is fixed with a hook placed between the first and second tracheal rings. Gentle superior traction to elevate trachea into the surgical field. So this is a video or animatory video of a tracheostomy procedure. Okay, here you can see that the incision, vertical incision in the neck from the cricoid cartilage just below the suprasternal notch, retraction of the skin, then subcutaneous tissue, then division of the strap muscles. This is the division of the strap muscles. Then you can see the thyroid isthmus. Then now we have to either cut or we have to retract it upwards. Now the tracheal tube is visible. Now next step is incision into the trachea. Okay, so we have put an incision into the trachea and we have inserted the tracheostomy tube. So this is the procedure for tracheostomy. Once you put a tube in the trachea, you have to confirm that it is in the trachea. For that, we can take a 5 ml syringe containing 4% lignocaine taken. It is needle inserted into trachea and aspirated. Air bubbles confirm the presence of needle in the trachea. You know that trachea which contain air. So when we put a needle into the trachea and aspirate, the outcome will be air bubble. So if you got the air bubble, you can confirm that you are in the trachea. Then we know that we have either vertical or horizontal incision for the skin. Then once we reach the trachea, we have to put incision again in the trachea to insert a tracheostomy tube. So these are the different types of incision. We can either put a T-shaped incision, box-shaped incision, H-shaped incision, cruciate or U-shaped incision. Okay, and we have another incision, that is inverted U incision, which is known as Jock and Duke's incision, which is the most commonly used incision because it prevents insertion of cannula anterior to the trachea. Then tracheostomy tube of appropriate size is inserted and secured by tapes. Lubricated tracheostomy tube inserted into the trachea. Then the most commonly used tubes are number 7 or 8 Shilley tube for adult male and number 5 or 6 Shilley tube for adult female. Then we have different types of tracheostomy tube available, just like Fuller's bivalve tracheostomy tube, Jackson's tracheostomy tube, red rubber tube, Shilley track tubes, and Bivona track tubes. These are the parts of a tracheostomy tube. We have inflation line, we have cuff or balloon, we have outer cannula, we have neck flange, we have a cuff port, and we have a syringe with air. Then after the tracheostomy procedure, we should ensure a proper postoperative care and we have to maintain the cuff pressure in 20 mm of Hg and we have to follow the protocol for trach air. So now let us see what all are the protocol for a proper trach air. So trach air means the cleaning of the tracheal tube. We know that when we are inserting a tube in the trachea, there's a chance of plugging of secretion in the tracheostomy tube and prevents the proper functioning. So, trachea involves a sterile technique for suctioning of the tracheostomy tube. So, before putting a suction tube, you have to hyperventilate the patient's lungs with 100% oxygen for 2 to 3 minutes before suctioning. Okay, and the trachea protocol will be like this. You have to do the trachea every hours for the first 2 days, then every 2 hours for the next 2 days, and every 4 hours thereafter. Then once you have put the tracheostomy tube, you ensure that the patient is in uh, proper ventilation, and you can remove the tracheostomy tube when indicated or the after the purpose over. So the removal of the tracheostomy tube is known as decannulation. So tracheostomy tube is plugged and patient observed. If patient can tolerate with plugged tracheostomy tube, then the tube can be removed. Then the complications, we have intra-perioperative complications and post-operative complications. Post-perioperative complications are hemorrhage, injury to esophagus, false passage, pneumothorax, subcutaneous emphysema, injury to recurrent laryngeal nerves. Post-operative are hemorrhage, tracheostomy scar, infection, plugging of tube with secretion, vocal cord paralysis, tracheal stenosis, and tracheoesophageal fistula. So these are the procedure, indication, contraindication, technique, and complications for tracheostomy. Thank you.